Welcome to this event, COVID-19 in Prisons, Strategies for Preventing Infection and Death, hosted by the Centre for Crime and Justice Studies. I'm Matt Ford, I'm Research Analyst at the Centre, and I've been leading on our work on COVID-19 in prisons, which we began last March. This is the second of 3 webinars in this series on COVID-19 in prisons, funded by the Hadley Trust. The first webinar, which some of you may have attended, we held in early December 2020, and we discussed the impact of COVID-19 on prison systems in a selection of European countries. So that was England and Wales, Scotland, France and Italy, and we had a particular focus on the impact of the size of prison populations in those jurisdictions. So what's today's event about? Well, prisons provide the perfect environment for this kind of disease, coronavirus, to spread fast and wide. They're cramped, often overcrowded, and full of people in bad health with poor access to healthcare, and they're insanitary. And in England and Wales, as well as globally, at the start of the pandemic, there were serious concerns about the numbers of infections and deaths that could potentially occur in prisons. One of our speakers will probably touch more on this, but there have so far been far fewer cases and deaths than projections suggested there would have been had the mitigation measures that Her Majesty's Prison and Probation Service put in place not been implemented. Although their strategy was not without other consequences, and there may be other ones which emerge as time goes on. Other countries fared less well, so the US is one example. At this key juncture, where there does seem to be light at the end of the tunnel in the shape of the vaccine, but whilst the potential for further outbreaks, including via other mutations, is a possibility, assessing the learning both from a UK context as well as internationally about how to deal with this type of disease in prisons seems appropriate. So what's the format of today's event? We've got 4 very knowledgeable speakers with us today, from a variety of backgrounds and from all over the world. Each will speak for no more than 12 minutes. And once all of our speakers have given their presentations, we'll have a question and answer session. And that's where I'm going to field questions to our speakers. But they won't be my questions, they will be your questions. So as we're going along, please put any questions and comments you have based on what the speakers are saying in the Q&A dialogue box, which you can see the icon for at the bottom of your screens. Please also upvote any ones that you like the look of, because that gives them more chance that we will ask them if they're really popular. Yeah, so please do that as we go along. We'll be finishing at 11 AM, so it's an hour and a half long, this event. We now have 170 people in the audience, and I know from the sign-up list that, again, that's an international audience, which is really good. Okay, so without further ado, our first speaker, Richard Coker, who's Emeritus Professor of Public Health at the London School of Hygiene and Tropical Medicine, is going to set the context for us by talking about his experience dealing with other diseases in prisons and the key epidemiological issues involved. Over to you, Richard.
Okay, good morning and good afternoon wherever you are. Thanks, Matt, and thanks very much for inviting me to speak. I'm going to talk about some general 3 themes that I've been thinking about during the COVID period. I'm going to talk about communicable diseases in congregate settings first, because as Matt said, these settings are uniquely excellent environments with which some pathogens can spread. You know, if we can think, for example, about SARS and in hospitals in 2003, we can think about cholera, typhoid in refugee camps. We can think about Norwegian scabies in hotels. Perhaps closer to home for some of you, lice and nits in primary schools, tuberculosis in prisons, something that I'll briefly return to, and obviously densely packed cruise ships, whether it's norovirus or new coronaviruses. So we know that these settings are important sites for the spread of communicable diseases. And the question is, why is that? Well, there are 3 intersecting elements to this. The first is the nature of the pathogen. The second is the nature of the host. and the third is the nature of the environment. And these three interact in different ways with different pathogens, with different diseases. So, for example, tuberculosis is airborne, and so close proximity, overcrowded conditions, poor ventilation. Scabies is skin-to-skin transmission. So if the host, for example, is HIV positive and immunocompromised, you get an enormous number of scabies, and transmission between individuals is enhanced. Or you can think about cholera, which is orofecal. So the transmission route is important. With COVID, you'll remember the debate has been around whether it's droplet or airborne or fomite. And to some degree that debate continues, but I think the overwhelming consensus amongst the scientific community is that it's overwhelmingly airborne, whether droplet or aerosol. The other thing that I'd like to introduce, perhaps, that we can discuss is this idea of control, and what do we mean by control? Is this institutional control, or is it an individual control issue? And I'll very briefly tell you a story about control. When I was working in the prisons in Russia, trying to support them addressing multi-drug resistant tuberculosis in the prisons, which were thought to be the epidemiological pump for the spread, for the emergence of multi-drug resistance after the collapse of the former Soviet Union. What was clear was that there was an incentive amongst some prisoners to continue to have tuberculosis, because the conditions in the prisons were so much better. If you had tuberculosis, you didn't have to do forced labor, you got a better diet. And so there became an economy for selling sputum. Now, this was an issue of control challenge for the institutions and for the country, but also it was an issue of control by individuals within that sector. And I think, although it's less important when it comes to COVID, obviously, but these issues around the control of our autonomy, actually, I think are very important, especially when you reflect on the long history of infectious diseases and the capturing of a sense of otherness and blame. The other thing that I think is really important to remember about COVID is the simple epidemiological factors around exposure, infection, what infection means, who infection results in disease amongst, what that disease is, what the comorbidities associated with disease and death are, whether it's related to sex and age as well, and ethnicity, and a wider variety of social factors. And this notion of long COVID, so protracted pathophysiological consequences arising from a disease that is still only a year and a bit old. The other issue, obviously, to think about in regard to congregate settings, but in particular in regard to prisons and other places of detention, is healthcare, and how does healthcare access and quality impact on the epidemiology and the individual consequences of disease. And we can perhaps talk about that in relation to prisons in the UK. I'm sure others know more about the circumstances than I do. And finally, I just want to finish off and sort of throw something into the loop here, which is about what the policy objectives of control are. And policy objectives, I think, are sometimes obscure. And I want to finish with a fairly graphic tale of, again, from working in prisons in Russia, but I think it illustrates where policy is not necessarily written, but implicit. And this was, I was working in a prison and we were trying to support the control of tuberculosis, but also, as a consequence, the control of HIV. And I'd met a prisoner who was HIV positive and a drug user. And I asked him, how did he get drugs whilst in prison? And he said it was pretty straightforward, but there were no needles. Well, he said there was one needle. And he turned around and he pulled a brick out of the wall. And behind that brick, there was one syringe and needle. And everybody in that prison was using that one syringe and needle, everybody who was an injecting drug user. Now, about a month or two later, I was in Moscow and I was talking to the minister of prisons in Moscow, and I was explaining what I thought was the necessity for effective harm reduction, needle exchanges and so forth in prisons. And he bent towards me and he said, "Dr. Coker, you don't understand. This is not the problem. This is the solution." Now, to me, this was a really eye-opening exchange, because clearly the underlying objective was not actually about HIV control. It was about controlling other populations. So I think we academics sometimes get a bit lost in our data and in our little narrow spheres. And sometimes we need to lift our eyes up and understand that there are sometimes policy objectives which take a little while to filter through. So I'll leave it at that, Matt.
Excellent. Thanks so much for that, Richard. Some really interesting thoughts there. Can I remind people, like I say, to be putting questions in the question and answer dialogue box based on what speakers are saying, and also upvote the ones you like. So there's one in there already. Okay, so next we'll hear from Nick Hardwick, who's a Professor of Criminal Justice at Royal Holloway University and the former Chief Inspector of Prisons for England and Wales. He's going to talk about his assessment of the prison services in England and Wales COVID strategy. Over to you, Nick.
Yeah, thank you, Matt, and good morning to everybody, wherever you may be. And thank you for the invitation to speak briefly this morning. Richard, I think, has set the scene really well in the way that you would, in a thought-provoking way, you would expect. And I want now to kind of focus now on a bit more about what actually happened in prisons in England and Wales, and what we can learn, what we know, and what we don't know. Prisons and COVID, what went right, which is a surprising question to ask. I put this is based on a paper I wrote back in the autumn. You don't need the web address actually, because if you Google what prisons and what went right, you'll find it, because there aren't many articles on what went right in prisons. And so perhaps this is controversial for that reason. So briefly then, to get myself a laser pointer, there we are. So briefly then, let's just think back to what the situation was in prisons in England and Wales prior to the pandemic striking. I mean, this will be familiar to the audience from England and Wales, perhaps less so to those of you, the international delegates, but the House of Commons Justice Committee rightly described, in my opinion, what was happening in prisons as an enduring crisis. And I think crisis is often an overused word, but in this context, it was correct. And I won't go through all the stuff, but, you know, extraordinary levels of violence and self-harm, overcrowding, prisoners locked in their cells for long periods of time, squalor, loss of experienced staff through staff cuts, surge in the availability of some drugs, etc., etc. Although perhaps it's worth noting that in the months just before the pandemic struck, some of the data was beginning to turn in the right direction. And that's a relevant bit of context for what follows. So you have a crisis before the crisis, prisons in crisis before the pandemic strikes. And then you have a population in prisons who you would think would be particularly at risk. We know there's an array of evidence that prisoners' mental and physical health is worse than the population as a whole. You have a disproportionate number of Black and Asian prisoners who appear to be the groups most at risk. And although prison population is younger than the population as a whole in England and Wales, we know that prisoners age prematurely and that older prisoners are the most rapidly growing section of the population. And how do you socially distance in an environment like this? As Richard described, you would think these were the perfect environment for which the virus to spread and a population who would be vulnerable to it. And for this reason, when the virus struck, the predictions about what would happen, predictions I have to say I shared, were dire. I remember the pictures of rats in Italian prisons. You know, Richard himself suggested that there would be up to 800 deaths in the prison population. I thought that was a very reasonable estimate. And Public Health England, in estimates they did in March and April, said here that if no action was taken, they expected 3,300 prisoners to be hospitalized and 2,300 prisoners to die. And they said that even, they looked at various scenarios, but even if an array of protective measures, from changes in regime to shielding of the most vulnerable, keeping prisoners apart, etc., if that were done, they believe that infections could be kept at 2,800, 200 prisoners would be hospitalized, and 100 prisoners would die. So what, in effect, actually happened? Well, this is the actual death rates. This is figures from that are published, they're initially published weekly and are now published monthly by the Prison Service of deaths in prisons and youth custody that are confirmed or suspected to have been due to COVID-19. So this is not prisoners who had COVID-19 who died, it's prisoners where COVID-19 was the cause of death. And you can see you have about 24 deaths in the spring. Then as the pandemic eases over the summer, that figure drops to 0. And in the autumn, as happens in the community, you see the numbers rising rapidly and rising to a level beyond that have been seen in the spring. This graph shows a positive test. Perhaps positive tests, which is the blue line, is a bit less relevant because it's a cumulative total there, because obviously it depends on the amount of testing that's done. But the red bars, I think, are more relevant, and this shows the numbers of sites of actual prisons in which there was at least one prisoner or child testing positive. And so again, you see the numbers starting to pick up here in September, and then the number of sites where there's infection growing rapidly until January, and then numbers of sites with infections dropping in February. There's another piece of interesting information, which is work done by Davis and Keeber from Nuffield. I think this thing is relevant in this context, which compares infection rates per 1,000 amongst the prison population and the population overall. So their work suggests that infections in prisons were significantly greater, 181 per 1,000, than in the community as a whole. And that's a very surprising finding, I think, and then raises the question why, if infections were greater, why, as we all, myself included, predicted that deaths would be greater, why weren't the deaths higher? And if you look at what the actual outcomes were, so you look again at the Public Health England prediction. So the kind of worst case, if nothing was done, 2,700 deaths, nearly 78,000 positive deaths. If you took an array of preventive measures, deaths could be reduced to 100, and total positive deaths would be getting on for 3,000. If you look at what has actually happened, the first wave, deaths much lower than expected. If you look at where we are now at the end of February, There have been 134 deaths, getting on for 14,500 people. Prisoners testing positive, 12 deaths amongst staff, getting on for 9,000 positive tests for staff. So what did the prison service do to reduce that? So first of all, they had this compartmentalization strategy where they, in a sense, separated vulnerable groups. So prisoners that were infected, new entrants into a prison, vulnerable prisoners, and they reduced movement. So they had this, what they call compartmentalization or cohorting strategy. They ran, as we all know, very restrictive regimes. Prisoners were pretty much kept in their cells for most of the day. They ameliorated that to some extent with the introduction of in-cell phones and remote visits. And critically, what they were able to do was to create some headroom in the prison estate. So they can only compartmentalize in the way that they did, and by reducing the prison population to create some headroom, right, so that they could keep people apart. And that was achieved not by releasing prisoners early, but by reductions in the numbers of prisoners admitted, because one of the effects of the pandemic was to create huge backlogs in the courts. So they got lucky. The backlogs in the courts reduced admissions, and consequently they had the headroom to do the compartmentalization that was crucial. They followed the advice of experts and public health authorities, and then they centrally directed this national framework for prison regimes and services. So rather than leaving it to individual prisons to manage the pandemic, it was very tightly controlled from the centre, specifying what degree of regime restrictions should be in place in each prison. And where we are now, prisons are in a lockdown stage, which is defined as offering the minimum required regime in place to ensure safety and decency. This graph, I think, is quite important. This shows, let me just see what this shows. So the red line is the usable operational capacity, how much space, how many cells they've got available. Right? And the blue line is the prison population. And critically, what happens here? As the population falls because of reduced admissions, that gives them the opportunity to reduce capacity, i.e. implement their cohorting and compartmentalization measures. And that's crucial to keeping the death rate here. Here it was lower than would otherwise be expected. But there was a price to be paid for this. There was a price for this extreme lockdown. And many people here will know there's widespread concern about the impact of lockdown on prisoners' mental health. Recent report by the Inspectorate said the cumulative effect of such prolonged and severe restrictions on prisoners' mental health and well-being is profound. But I think I think the evidence about the effects is more ambiguous. Salts have fallen, that's hardly a surprise, prisoners were locked in their cells. But it is very surprising that self-harm rates have fallen overall. So this graph here shows self-harm rates. This is the line for adult prisons. So you can see self-harm rates dropped here in the first period of lockdown, and self-harm rates began to rise again slightly as restrictions were eased. Right? In women's prisons, the figures rose overall, but the rate here did kind of flatten out as a lockdown was imposed. Now, self-harm may not be a very good indicator of mental distress, but it surely must be one indicator. We need more evidence, but I think this fall in self-harm rates is something that needs some explaining if the consequences of lockdown on prisoners' mental health was as severe as is suggested. So I think we need more evidence, but this at least should cause us to think carefully about how the impact of lockdown and whether it had the effect that we all thought it would. So I'll end, I think, just with some questions that this data raises for me, at any rate. First of all, what's the explanation for what seems to be a higher infection rate in prisons than in the population as a whole, but a lower death rate than expected? I mean, for those in England and Wales, can you think of another public institution where the death rate from COVID was so much lower than expected? Maybe there are some, but I can't think of them. What accounts for the different death rates in the first and second waves? The prison service was criticised for keeping lockdown after the first wave in place for as long as they did. Is there an alternative argument that says they eased restrictions too soon, and if they hadn't eased restrictions as quickly as they did, the death rate could have been kept lower still? A similar argument has been made about lockdown in the community, of course. The self-harm rates appear to be very different in different prisons. So there wasn't a uniform fall. Self-harm rate did go up in some prisons and it went down in others, even in prisons of very similar types. They did on the whole go up in women's prisons, but what accounts for the difference? Perhaps it's a recording thing. Perhaps they weren't recorded accurately. Perhaps these virus spread in different ways. Or was it down to the way in which the lockdown was managed, the management of the prison? And I think the next question is, can prisons be kept free of the virus when the prison population begins to rise again? Which of course it will, as quite apart from long-term trends, as the court backlog is reduced. So there is a threat coming down the tracks towards us. And if, as is suggested, will happen in the community, infection and death rates rise when restrictions in prisons ease, how should the balance be struck? So we know that in the community, that a consequence of children going back to school, lockdown easing, all good things, we know, we've been told by Chris Whitty and others, that death rates in the community will rise. If we ease restrictions in prisons, do we also know that death rates in prisons will rise? Is there a balance to be struck then between easing regime restrictions and the death rate from COVID that is acceptable? And given that prisoners aren't in a position to manage their own risks, does the state have a greater obligation to keep them safe than would otherwise be the case? Sometimes this is reduced to a simplistic argument about how much time prisoners spend in their cells. I think we need to focus much more on what prisoners are doing in and out of their cells. We should focus more on the quality of time they're spending out of their cells and the quality of time they're spending in their cells, rather than saying, it's a good thing they're spending 10 hours a day out of their cells, even if actually they're not doing anything and they're getting beaten up. And finally, what lessons can be learned from the management of the COVID-19 crisis that are relevant to the management of the enduring crisis that existed before the pandemic? So if it is the case that the prison service managed the COVID-19 crisis reasonably well and had better results than we expected, are the lessons that can be applied after the pandemic, from their management of the pandemic, that can be applied to managing the crisis of safety and decency that has existed for far too long? So that kind of finishes with more questions than answered, but I'm looking forward to discussing it with people in the question and answer session.
Okay, thanks Nick, for that very even-handed assessment of the strategy. The Q&A is getting nice and full now. Let's just quickly ask you a question rather for your mental health, but I think this is quite an interesting one. Given what we now know from HMP about the impact of the restrictions that they implemented to contain the virus, why was early release not effectively implemented? I know they originally said about 4,000 up to 4,000 prisoners could be released. Only a few hundred have so far.
Well, it's good. I didn't touch on that in the time available. It was a big failure. They need to. In the end, they got away with it because the numbers of admissions fell. But the early release scheme was simply so bureaucratic, it was just unworkable. Mm-hmm. But I think what's going to happen is, I think as the court backlog eases, you're going to get a surge in the prison population. There's long-term pressures for the prison population to rise. I think the virus won't go away completely. And so unless you do take measures to reduce the population by releasing some low-risk prisoners early, I think there's a danger. The danger of the pandemic in prisons has not yet passed. So I think that the need to reduce the population and reverse the upward pressure on population remains as important now as it did at the start of the pandemic.
Excellent. Thanks so much for that, Nick. So if we now move on to our next speaker, so Dr. Felipa Alves da Costa from the World Health Organization Europe's Health, Alcohol, Illicit Drugs and Prison Health Programme will talk about the WHO's research into the implementation of the World Health Organization's interim guidance on preparedness, prevention and control of COVID-19 in prisons across learning and the learning which emerged across Europe and the learning which emerged from that. Over to you, Felipa.
I'm going to refer to the strategies that have been used for preventing COVID infection and death in prisons. Okay, sorry. So I was asked to refer to 4 specific points. So one of them is the background, which I will not detail very much because it has already been approached by previous speakers in a very eloquent way, so I will not be able to add much. But then I'm going to try and show you some data from the European region on how COVID impacted people deprived of liberty, and also the overall trend in the response measures that were adopted Europe-wide. So this is just a background information, which as I mentioned, will not detail, but I would just like to mention that all over the world, we have around 11 million people held in penal institutions, and 1.5 of them are just in Europe. So we all know that the risk for these people of getting an infection is higher for varied reasons. And this data just shows some global estimates that we collected across 79 countries in June 2020, so just after the first wave. And we had, and you can see here on the map on your right-hand side, that all these countries that are highlighted in brown, they are cases where they have infections among staff members and also among people living in prison. So we have outbreaks that have been recorded in a large number of European countries. These are just a few: Poland, Lithuania, Moldova, Slovakia, Sweden, etc. But also at the same time in European prisons, we know that the spread of the pandemic was accompanied by a decrease in the prison population, which was taken up by 35 prison administrations. So only a few countries had some exceptions in adopting this rule, but most of them did adopt this measure. So we at the WHO Europe collected some data on the infection that was voluntarily reported by member states to be able to observe some trends. And what we can see here on the left-hand side is the general trend that was observed between May and October in the countries that were reporting data. So of course, not all countries are reporting, so there's some underreporting in this graph. But what we are trying to see here is the comparison between what is happening in prisons and what is happening in the general community. And you can see that up to October, the blue line is always, with some exceptions, lower. So indicating a more controlled situation in prisons. Now, this situation changed recently from November onwards, and the trend that you can see here on the right-hand side has emerged in some countries, where you can see that as as soon as the infection rate rises in the prisons, so the blue line here, then there's a clear effect of amplification of effect, and they just go broader and become more separate from each other. And this happened in quite a few countries. So what we do in this situation is that when we get these reports, this triggers an internal mechanism where we contact countries and develop some virtual missions to try and understand what is going on, what is failing, so that we can support. And we see in some countries, it's just they just need additional information on the most updated guidance, but in other countries they do not have enough resources to be able to develop the advised measures. So in terms of the third point, the most frequently reported practices, we collected data from countries all over the world, actually not only from Europe, but the most frequently reported practices are here listed on the left-hand side, and certainly the one that's been most applied was the early release for non-violent and non-sexual offenders. And on this map on your right-hand side, you can see data from Harm Reduction International, where it has been shown that 109 countries worldwide took these measures, and they have reduced the prison population by around 6%. So as it was shown by Nick, this is a slightly lower value than reported for the UK. But the general reduction in Europe is indeed lower than the one reported for the UK. But there were other measures that were also applied. And some of them are in fact not directly related to COVID. So you can see here some of the pictures. So this one is in fact in Kazakhstan, where they have used people even in prison to produce masks because they didn't have enough to be able to implement this measure. But in other countries, like in Spain, for example, and this is Northern Ireland, some of the measures were indirect and were mostly intended at preserving the mental health and well-being. So this one is a public health campaign directed at drug users, and this one is mostly describing some measures that were created to maintain people engaged with peers and also with external people. So the last point I would like to mention is the WHO interim guidance. So in March 2020, we have developed this guidance that was intended to focus on specific measures that were advised for prisons and other places of detention. And we have now recently published an updated version of this guidance. And in some of the updates that are included refer to case definitions, which have changed, also the transmission scenarios, and then above all the prevention and control measures, which have changed quite a lot since March, and also the management strategies. In this updated guidance, we also refer to additional issues that were not covered in the previous guidance, including the vaccine availability and allocation procedures, and also some indicators that are advised for surveillance purposes. So I'll just briefly highlight a few of them. So one of them is the use of masks. And currently what WHO recommends is that the masks should be part of a comprehensive package of IPC measures to limit the spread of SARS-CoV-2. And the same general principles that are recommended for the public are also considered suitable for use in prisons. So for healthcare workers, we apply those principles that are applied to healthcare facilities in the community. And then we have specific recommendations for areas where there is suspected community or cluster transmission. And these are the ones that you can see highlighted here on this text box on the right-hand side. In terms of testing, so the most recent recommendation is that suspected and probable cases should be investigated. But of course, we must bear in mind that normally when WHO issues guidance, we try to think of guidance that's applicable to also low resource countries. So in this recommendation, we have the ideal situation, and then we have the situation that's advised for low resource countries. So the priority that we advised is to test primarily those that are coming into prisons, in addition to quarantining, of course, before they are joined into the general prison population. And then we have some recommendations that are focused on the early identification and protection of vulnerable people and healthcare workers. So we recommend prioritizing the vulnerable population, healthcare workers, and the first symptomatic individuals in prisons. Of course, when countries have the ability to perform a whole prison approach to testing, that is the ideal situation and is also referred in the guidance. So this was also an aspect that was quite detailed by the previous speaker, the prevention and management strategies. So of course we advise quarantine as we did already, but we advise quarantine for contacts and also for people that are coming into prisons, as I just mentioned. But of course, we must have in mind that not all countries will have the possibility to quarantine people in single cells. So we have the possibility to have refined allocation procedures where people are separated based on their risk of complications or poor outcomes. In terms of management strategies, again, as explained, we have medical isolation advised, which is the separation of suspected or confirmed cases, but we also foresee the possibility of having cohorting strategies in place to minimize the risks and make this measure feasible in practice. In terms of contact tracing, the only difference in the current guidance is that we advise contact tracing to begin immediately after a suspected case has been identified without waiting for the laboratory results in order to prevent the delays in implementing health measures. So vaccines, that's probably the issue that has not yet been debated in here. So what we recommend is at least to follow the principles of the Mandela Rule. So the basic principle of equivalence must be followed. So meaning that at least the priority groups that are defined for the community should be the same that are also included in vaccination rollouts in prisons. So this means healthcare professionals, non-healthcare staff providing services that carry significant risks of infections, and older adults. Of course, if the country has the availability to go further than that, then we would recommend a whole prison approach to vaccination, and ideally that should be followed because of the highest risk of this population. So I believe I'm about to be made quiet. So this is my last slide. I just wanted to mention, because this is really in line with the data that has been presented earlier. So we have included in this guidance a number of indicators that member states should be reporting. And these are here on the right-hand side. And these are the minimum that we recommend for surveillance purposes that would then allow us to compare with the community, as I've shown you in some of the graphs. So in this one, we added one, that's the number of people vaccinated against COVID, and ideally disaggregated by the type of person vaccinated. So healthcare professionals, prison staff, and people in prison. So thank you for your attention, and I'll stop sharing now.
Thanks for that, Felipe. That's really good to get a more international overview from what's happening across the board in Europe. We've got loads of stuff happening in Q&A now, which is really good. So I just have a quick question for you, and it kind of relates, I suppose, to what Nick said. Did you find any examples where you thought it was a particularly good strategy? You know, there was a particularly good example in Europe of someone implementing a strategy which was, you know, optimal, very healthy, and led to, you know, low rates of infection and death?
Yeah, well, it's difficult to answer that question because I don't think there is an ideal country. There's different countries doing specific measures very well, and that's exactly what we have portrayed in this report that we hope to be publishing very soon, where we show that some countries are doing very well in prevention, some countries are doing very well in case management, others are doing very well in the prevention of side effects of COVID, like the mental health I've just mentioned. Mm-hmm. So answering directly, no, I don't think there is one country doing everything well.
Excellent. Excellent. Thanks so much for that, Felipe. If we now move on to our final speaker, and that is Samson Nseko, who is a lawyer and advocate in Uganda, and he's also a project coordinator for Prison Reform International's Africa program based in Kampala in Uganda. And he's going to talk about what happened in the Ugandan prison system and the learning from that. So over to you, Samson.
Thank you so much, Marta. Very good morning to wherever you are, and still morning hours. Here in Uganda, it's afternoon, and those who are elsewhere where it is afternoon, good afternoon. I'm so glad for the opportunity to make a presentation here, and thank you so much for the invitation. I was invited to present an experience from an African country, a non-European country, so I chose to take an example of Uganda, and I'll be giving you our experience on the strategies that we undertook to prevent infections and deaths in prisons arising out of coronavirus. I'll take use of the presentation. In Uganda, we so far have confirmed cases of 637 in prisons, and of these, 307 have recovered. We do not have any registered deaths in prison. This is out of a total population of about 62,000 in prisons. Okay, the preventative strategies that we took in Uganda, they are not any different from those that have been presented by Dr. Flipper. The first one was to institute a total lockdown of all the prison facilities. Now here, admissions were only allowed in a few prison facilities, which had a small numbers for purposes of isolation And this is where the 14 days mandatory quarantine was administered. So all the newly admitted prisoners would be taken to these isolation centers, where after the 14 days, they would be taken to different prisons in their respective home areas. There was also suspension of taking prisoners to courts. The courts were not operating, and therefore no prisoner was presented to court, except in a few prisons, like I think 5, which could afford virtual court process. But in most of the prisons, courts were not going on. Therefore, even prisons would not take prisoners to court. There was also encamping staff inside the prison facilities. This was intended to reduce movement of staff from the prison facilities to their quarters, to the public, which would put a higher risk of transmission from maybe the public to the prison facilities. So all the staff were encamped in different prison facilities to avoid such movements and subsequent transmissions. There was also total lockdown of staff quarters. Staff would not be allowed to get out of their quarters. They would not be allowed to get any visitors. This was also intended to reduce infections from the community arising out of visitation to the different prison quarters, which would also subsequently lead to transmission to the prison facilities. There was also establishment of treatment centers. The prison institutions established 4 treatment centers where prisoners could be treated. Any cases that were identified were referred to these treatment centers for medical attention and diagnosis. We also had strategies aimed at decongesting prison facilities, and one of them was pardon. 833 prisoners were pardoned by the President of Uganda in exercise of his powers of the prerogative of mercy. However, there was an issue of transporting the pardoned prisoners to their respective home areas, given that public transport had been shut down. So there was an issue that even those who had been released could stay in prisons. So Penal Reform International, the African office, came in to assist about 290 released prisoners to transport them to their respective home areas in a bid to reduce under congestion. Talking about congestion in prisons, we have 259 prison facilities with a total capacity of about 19,000, but yet our prison population is in 62,000 prisoners as of now. So therefore, there was a lot of congestion in the different prison facilities, which raised a lot of risk because they could not observe social distancing as required by the Ministry of Health and also internationally by the World Health Organization. However, these strategies had limitations. There was a lot of infringement on the right to fair hearing and access to justice for prisoners. As I mentioned earlier on, one of the strategies that was taken was to suspend presenting prisoners to courts. So most of them could even go beyond the mandatory remand period, but still stayed in prisons. Even those who had chances of release on trial, they could also not access justice. And this eventually led to a subsequent suit, which was instituted by Human Rights Awareness and Promotion Forum against the Attorney General and the Commissioner of Prisons. challenging the legality of denying prisoners access to their lawyers and access to courts. And this was a successful suit, leading to a lot of award to the affected parties. There was also overcrowding, given that courts were not operational, there were no releases, and there was also increase in admissions, in the enforcement of curfew regulations, and other restrictions that were put in place in a bid to prevent the spread of COVID-19. So there was a lot of increase in the prison population by about 15,000. This was a drastic increment in just a few months from the rise of COVID-19. There was also a limitation on monitoring of living conditions and the state of human rights in prisons by both government and non-government monitoring bodies. Therefore, until now, we are really not very certain of the human rights situations in the different prison facilities because of the limited access to the prison facilities. Therefore, given that, we could not monitor the places of detention effectively. Out of these strategies that we took, we've come to learn many lessons, but among these we have the most catchy one is that it's time that governments realize that whenever we design a response to any pandemic, all the strategies developed must be in compliance with a few, if not all, the human rights standards for treatment of prisoners, especially the strategies that are designed to focus to the prison community. Given the above strategies that I've discussed that we undertook, there was a lot of non-compliance with the Mandela rules and the Bangkok rules. For example, prisoners were totally denied the right to be visited by their relatives. There was no access to legal aid services, access to lawyers. So all these were in violation of these human rights standards for the management of prisons and places of detention. I think it is also high time that countries develop plans to ensure effective access to justice and delivery of justice, even at times like the ones of pandemic. For example, we've not been having access to justice. Courts were shut down. It was really so absurd that the institution of justice was not considered among the most relevant institutions or services to be left open even amidst the pandemic. Whereas we had the institution of health, the institution of agriculture, for them they were left operational, but the institution of justice was one of those that were shut down. And then lastly, I think it is also high time we realize the vulnerable nature of prisons and the prison community. I'm saying this because I'm taking the example of Uganda. We have recently started off the vaccination program, but however, the prison community is not among the priority community that was considered for the vaccination in the start. They considered education, they considered health and security, but then the prisoners were not considered as priority for vaccination. So I think these are some of the lessons that we've gotten out of the pandemic, and I thank you so much for listening.
Thanks, Hobson. Thanks, that's a really good contribution. I think in the Q&A, we're going to particularly come back to what you were just saying about vaccination. However, there was just a very quick question of detail that Peter from Yorkshire has asked. What is SMR that was on your last slide? What does that abbreviation stand for, please?
SMR, that is the standard minimum rules, which are also known as the Mandela rules.
Brilliant, excellent. Cheers for that.
Yes.
Brilliant. Okay, so if all of our panelists want to come in now, the Q&A has been really active, and we've got a few kind of like themes to address. So I think the first one is about kind of, looking forward and possibly more long-term effects. So one from an anonymous attendee, which is about what speakers' thoughts are about how transmission will be impacted when prisons reopen to the public and when the courts start, processing more and more cases. And there's also one from Emily Giles, which is about, do you believe there will be any long-term changes based on learnings from this, or will things go back to the status quo? So should we start with Nick for these ones?
Yeah, okay, thank you for the questions. Well, I'm not the expert on epidemiology, but if, as is suggested, that deaths and infections will rise in the community when restrictions are eased, you would expect deaths and infections to rise in prisons when restrictions are eased. I guess the vaccination program will have some effect on all of that. But be very clear, the prison population is going to rise in alarming ways. So first of all, there are long-term trends arising from sentencing changes that will push the population up. But secondly, there is now this huge backlog in the courts, which the government is working very hard to reduce. So as they reduce the backlog in the courts, it's going to sort of go down the pipeline, as it were, like a wave, and hit prisons. Right? And I think that will, I'm very worried about how the effect of that. Right? Secondly, in terms of what the long-term consequences will be, we will only, I'm sure there are positive lessons to be learned, but we will only learn them if we are prepared to think openly about what they may be. And I think it's a real risk in some of the debate I've seen. Everyone's already kind of disappearing into their trenches. And actually, I think we need to reflect very carefully about what's happened. And it may be that we won't be able to properly understand it for some time, but I certainly think this is an opportunity to change. And we certainly can't, in prison in England and Wales, we can't just go back to the appalling situation that there was before, that we all, I think, sometimes are worried, everyone's got a bit used to it. There was blood on the floors from the level of violence, and we can't go back to it.
Excellent, thanks, Nick. Richard, do you want to also address those questions, please? I can remind you of them if you want.
Yeah, no, I'll address the first. I think it's really interesting because Nick highlights a question that that I think many of us have pondered about. How can you have an increase in infection rates, which was anticipated in prisons, but not have the death rates that were expected? It was Andrew Haywood, the modeler at UCL, who back in March, I think, suggested about 800 deaths might accrue in the England and Wales prison system. But let's take ourselves back to February, presumably when he did that work, February 20. So the data was largely drawn from the Chinese experience. And this was a lot of case fatality rates rather than infection fatality rates. And the difference being that case fatality rates is known cases that subsequently die. So those generally are more serious than those of the whole population who have an infection. And the Chinese experience, the mortality in Wuhan was a fair bit higher than subsequently rolled out in most places, not everywhere, but in most places. So the extrapolation was probably erroneous. Well, it was erroneous because the reality showed that it was different. So the modeling, I think, was a little bit flawed, but for reasonable, understandable reasons. The second issues are that the identification of people with asymptomatic and early or relatively asymptomatic mild disease has improved, but then also remember treatment has improved, and treatment's improved considerably, both in intensive care units, early use of dexamethasone, and so forth. So one would expect to see a reduction in mortality in those cases. And then on top of that, you've got all of the increased awareness, early access to care, compartmentalization, isolation. So I think throwing all of those things together actually explains why the mortality rate is not as high as expected. Going forward, I don't expect the mortality rate to be particularly high, actually, for the same reasons. But I do expect, once you start to get overcrowding, that the infection rate will get high, which is what I anticipated last year, and I think it was borne out. What's the magnitude of that rise in the prisons, I think, is really difficult to determine. And part of the reason is because the surveillance in the prison system isn't harnessing some of the technologies that we could be using. For example, pooled sampling, frequent testing of pooled samples, sampling of sewage samples, phylogenetic testing to look at whether it's clustering or whether it's repeated introductions. So there's a vast array of surveillance data that could be harnessed to understand the outbreaks and the expansion and potential for epidemiological pumping that we're not, I don't think we're interrogating either in the UK or around the world sufficiently, actually.
Why are we not monitoring that, Richard, by the way? Why is that?
Nick, I think that's a question for you. Well, you don't monitor things because sometimes you don't think of them, or sometimes you don't want the answer. I'm pretty sure this has been thought of. In fact, I remember doing a report back in maybe 9 months ago that I understand one of the university, I think it was Southampton University, has been funded to do a large surveillance program in prisons to answer some of the questions that I was just posing there. I haven't seen anything out from that. I don't know whether that was pursued, but this isn't, some of this isn't rocket science. The UK is basically one of the epicenters for phylogenetic analysis. So we should be able to be looking at clusters in congregate settings to determine whether they're epidemiological clusters or just geographic clusters.
Excellent. Okay, and Philippa, do you want to come in on those questions as well, please?
Yeah. So I think one of the issues that was raised was how the transmission will impact when prisons open to the public, and actually the measures, there's not a European unified approach, not in prisons and not in the community. So what we see is that countries are going at different paces in terms of implementing the measures. So your question, I believe, is very much based on what's happening in the UK, but this is not the situation in all the countries in Europe. So in Portugal, where I live, for example, prisons are now open to the public already, because we're coming out of one confinement, although in Italy, for example, it's exactly the reverse. They're going back to the more intense strategies. But of course, when the openings are back, it doesn't matter if it's in prisons or anywhere else. What we see is an evolution in the cases that appear, and it will depend a lot on the measures that are implemented. So in schools, for example, there are not lots of new measures that are being implemented for children to be able to go back to school, and the same in prison. So in some countries, for example, one of the new measures was to reinforce the testing. You also saw that in Nick's presentation, where the testing in the UK is rising considerably, and there are more countries doing this. Also, the types of opening depends if you're talking about the visits, or if you're talking about the going back to the non-custodial measures. So in terms of the non-custodial measures, yes, we are already observing that the decrease that was seen before is already reverting back to an increase in most of the countries. So of course this will impact on the cases. However, yeah, I mean, WHO has been defending the adoption of non-custodial measures for long, together with other agencies. And we continue fighting for this, although it's up to the countries to adopt them or not. One aspect that you also asked was the difference in terms of mortality rate. And I think one of the comments that was also included in the chat is relevant in this aspect, which has to do with the structure of the prison population. So we see that in most cases, we do not have people as old in prisons as we have in the community. So this, of course, impacts, even if we consider that there is not a direct equivalence of 65 years old in prison and 65 years old in the community, but still this impacts. But from a European perspective, the main point I want to bring with this is that not all countries are even aware or able to count the proportion of elderly they have in prison. And this is scary. Like, if they cannot even say their population, how can then they say the proportion of infected that are older, or the proportion of those who die who are older? And one of the hopefully, one of the advantages of this pandemic will be that countries start understanding the benefits of strengthening their surveillance system. So, of course, UK is a very good example. You probably think of bad things about it because you live there, but in European terms, it's an excellent example. You have all the data, but this is not the general reality. Yeah, and I would say that is what I'm hoping that this will improve in the future. Above all, is the country's awareness to invest in good information systems for prisons.
Brilliant, thanks, Felipe. Yeah, I mean, I think England and Wales is very, very good at collecting data across the board for their criminal justice system, so and producing it quite frequently. So, Samson, is there anything you want to add there in terms of those questions? Maybe on the one about the long-term consequences in the prison system in Uganda, and whether it'll have any impact or things will just go back to normal, basically.
Thank you, Martha. I would like to respond to a question from John Watts. He was asking whether there is any moral obligation to prioritize vaccination of prisoners. And I would like to say yes, there is, because as we heard from Flipper, the World Health Organization advised that we consider taking priority of the vulnerable groups of people. So if we are taking priority of vulnerable groups of people in the community, in the same way, we should realize that even prisoners, they are vulnerable people. It's a vulnerable community. Therefore, if we are prioritizing vaccination of vulnerable groups of people in the community, in the same way, we should take priority to vaccinate prisoners, because in the same way, they are also vulnerable. Matt, also asked about the long-term impacts. The long-term impacts of COVID-19. One of them, I think it was Nick who discussed about the self-harm, the rise of self-harm in prisons. Even in Uganda, it also increased. Because of the long-term lockdown, they could not access courts, they cannot access their relatives, they cannot even access psychosocial support services from the different organizations. There was a lot of rise in risks of self-harm. Even risks of escape. For example, I'll give you an example. I think it was in November, we had a massive escape in Uganda here from one of the maximum security prisons. And it was because it was linked to COVID-19. There was an isolation point at the prison, but the same isolation point, they were sharing facilities with the rest of the prison community. And this, because of that fear, many prisoners escaped. I think it was about 120 prisoners who escaped, but it was all linked to COVID-19 management. So true, there is a lot of long-term psychological and physical impact arising out of COVID-19, and I think it is high time that the prison authorities think about investing much in how to counter these effects. Thank you so much.
Brilliant, thanks, Anton. You got ahead of me there with the vaccination question. That is what I'd like to ask now. So basically to panelists, whether they think that prisoners should be prioritised, obviously in the same way that care homes were prioritised in England and Wales for vaccination. So do we want to start again with Nick and go around again?
Yeah, thanks. I think there's two views, or two factors to take into account in this. I mean, one is, I think ethically the right thing to do is vaccinate prisoners strictly according to their personal and public health risks. So that should be the only criteria for deciding when somebody gets a vaccine. What's the risk to their health? How does that compare with others in the community? What's the kind of public health risk of them spreading the infection? Their status, I think, shouldn't come into it. I think there's a political argument about this as well. I think those people who are arguing and not using, without the scientific evidence that somehow or other prisoners should be pushed up the queue, I think that's quite a dangerous thing to argue, because once you start making special cases to push people up, you can then start to make special cases to push people down, and you then start to differentiate between different groups, and I think prisoners are likely to lose that argument. So my view is you keep it very straightforward. What's the individual health risk? What's the public health risk? Decide on that kind of expert scientific this. And I think prisoners will be best served by, as far as possible, keeping the kind of politics and sort of pressure groups out of it.
Excellent. Philippa, do you want to come in on that? And just, I think you might have already mentioned what the position of the WHO is.
Sure. So WHO's position on this is quite clear. We do not defend prioritizing of people in prison. We do defend inclusion of people in prison in vaccination plans. And this is because not in all countries they are being included. And in some of them, even across the US, for example, there's across states, you see in some states they're prioritized. In other states, they're just saying when everybody else is vaccinated, then the shortages the leftovers will go to people in prison. So of course we cannot agree with that. So I think, yeah, that is the position for sure. But there is also one other issue that should be considered, and that is the availability of vaccines that is very different across countries. And in some countries where there are enough vaccines, the prisons have a good aspect in terms of feasibility, because it's a closed environment, right? So you can easily vaccinate everyone in that environment. And the feasibility issue in some countries is problematic because they don't have centralized records to be able to be calling people according to the different strata that are established in the general population.
Excellent, thanks. And Richard, do you want to come in? You might have a counterpoint. You don't need to have to, but no pressure.
Yeah, thanks, Matt. I very much agree with the previous two speakers. I think one of the ways to look at this is obviously the individual and the public health risk. And then when we think about the transmission dynamics, what I think is interesting is that we can sort of separate prisons in a sense I'm not sure if there's a problem with the sound actually, but we can separate. Okay, we can separate prisons in a sense and think of them as outbreak environments and pumps towards to a larger community, and that's very different from thinking of an endemic infection. So actually, if they are epidemiological pumps, and I think there's a bit of debate about that, but if they do pose that risk, then actually you can saturate that population by vaccinating prisoners and visitors and staff, and then you have a population that is protected, that no longer serves as a leakage into the wider population. And I think Philippa's point about feasibility, accessibility is a point well taken, that you can create communities within a wider population that are, in a sense, they're bubbles of protection which expand outside.
Excellent. And just a point, what do people think about the vaccination of prison staff, say?
There is just a point to make on prison staff, I think, because obviously the way that, on the whole, the biggest sort of transmission of the virus into and out of prisons is going to be staff, certainly during lockdown. And I think there is some evidence that the take-up of the vaccine that's been offered to staff in England and Wales has been quite low. And I think it's fairly urgent to try and address that and persuade us, get staff vaccinated as quickly as possible. I certainly think, and I guess the health issues will be slightly different for staff and prisoners, but I think where the vaccine has been offered, I think it's really important to encourage prisoners and prison staff to take it.
Actually, can I just jump in there, Matt? I think it's a really important point you raised, Nick, because if you look at nursing homes and care homes, it's very, very important to vaccinate those working in care homes, because they're moving virus potentially between the most vulnerable. So it isn't only those who are vulnerable that are transmitting.
I would just like to add that in general terms, what we can see is that there are many more countries adopting the inclusion of prison staff as one of the priority groups than of people in prison, and the rationale has been explained. So that's quite clear. The only additional point is that in most countries also there is this previous phase where it's being collected, the person's willingness to be vaccinated. And according to the WHO's position, this should be at least rethought, because it's, my freedom to deny something will impact on the freedom of other people. So the current recommendation is that there shouldn't be this phase, really.
Excellent. Okay, so we've got about 6 minutes left. I think another important theme that was coming out was about the experience of imprisonment. Some of it was touched on in your answer about long-term effects, Samson. But there are, so I suppose what people think might be the long-term mental health impacts. I mean, I know, Nick, we've touched upon how self-harm and self-inflicted deaths were actually, what the trend did not go how was expected. But also, Susan McGregor has been asking about, in lockdown, do prisoners feel and are more secure because there's less mixing? So, that might have impacted on, things like self-harm and so on. And what people think about how that will actually play out in the long term, basically, in terms of mental health and so on. So if we have, say, a minute each, starting with Nick on those issues, if they're clear enough.
Well, one of the first of all, we don't know yet what the long-term impact is, because we're not into the long term. I've certainly seen some people suggest that, in a sense, as in the community, so people sort of holding it together while lockdown is in place, then the psychological harms may emerge when people, in a sense, feel a bit less under pressure. Right? But I think the interesting thing about prisons is about the variations between what seems to be happening in different prisons. And so certainly there's anecdotal evidence that in some, prisons were kind of locked down and then more or less left to it. In others, prisons, there seems to be some evidence or some anecdotal accounts that staff use the time that they weren't supervising groups of prisoners to pay particular attention to the most vulnerable. Right? Now, I don't know whether that's true, so we need answers to some of those things. And I also think it's the case that, of course, the levels of violence affected people's mental health. And there may be something about how we manage the time people spend out of cells. Maybe they're, huge groups milling about in association and cats in big prisons. We could keep people in smaller. There are lessons to be learned about that. And the people who will know the answers to it are prisoners themselves, largely.
Excellent. Thanks for that, Nick. Philippa, do you want to come in on that as well?
Yeah, I would just add that one of the changes that we have been seeing, not directly related to mental health, but could also be applicable here, is the trend of resorting more to technology for the provision of services. So in most prisons, there are not enough psychiatrists, psychologists, name it. So this can be a long-term solution that has been implemented in a few countries, and hopefully it will be taken up by others.
Excellent. Thanks for that, Philippa. Richard, do you have anything to add to that?
Matt, I'm afraid I don't have anything to add on that.
That's all right. And Samson, anything to add on that? I know you already touched on that issue.
I think I need to agree with Philippa. It's about addressing these mental health issues that arise out of COVID-19. It's about having specialized psychiatrists attributed to each of okay, it may not be each, but at least to a bare minimum of the prison facilities that do have risks of mental health. Because I'll give an example here. You could find that out of 10, you may get 0 prison facility that has a psychiatrist. Then a psychiatrist has to move from one district to another to attend to different clients. So I think it is high time we invested in mental health, both on research and medical attention. Thank you.
Brilliant, excellent. Just in time as well. We've reached the end of our time here today. I'd like to thank our 4 brilliant speakers for their presentations and their contributions to the question and answer session. I'd like to thank everyone in the audience as well, like I say, wherever you are in the world, for listening and for your comments and questions to the speakers. There's now 40 questions in the Q&A and comments, so obviously, sorry we couldn't get through them all. In our follow-up email, we will ask for some feedback on the event, so please do give us that, just because it helps us improve our events and make them more relevant to our audience. We'll also send a recording round of the event. And as I said at the beginning of this event, this is the second of 3 webinars on this topic. The next we'll look at how we ensure that in future the safest and most effective strategies to tackle pandemics in prisons are implemented. And that was actually one of the questions that was raised in the Q&A. So you're ahead of us there. And we'll be holding that event in June. So please do stay tuned, as we'll send invites to everyone who attended this event. So thank you and have a good day, everyone.